Hello, welcome to this live interactive webinar hosted by the Alliance for Food and Farming to discuss farming and produce safety in the COVID-19 era. This webinar has been approved for 1.5 continuing professional education units. My name is Elizabeth Shaw and I will be your moderator today. After 4 months of growing, harvesting, and shipping fruits and vegetables during a pandemic, the agricultural community has learned a tremendous amount after facing numerous challenges that have arisen during these uncertain times. The scientist and farming community joining us today are going to share what they've learned over the last few months while discussing future challenges that could be faced as agriculture continues to work to provide an adequate supply of safe and healthy foods for consumers in the midst of COVID-19. First, we will hear from Dr. Leanne Jaykus, William Neal Reynolds Distinguished Professor in the Department of Food, Bioprocessing, and Nutrition Sciences at North Carolina State University. Dr. Jaykus focuses on food microbiology with specific interest in microbial food safety. Much of the work done in her lab focuses on the study of the transmission of enteric viruses through the food chain. She currently directs the USDA NIFA Food Virology Collaborative, also known as NORCOR. Next up, we have Dr. Trevor Suslow. He is the Vice President of Food Safety with the Produce Marketing Association and Research Extension Specialist Emeritus of the Department of Plant Sciences at the University of California, Davis. Dr. Suslow's food safety expertise spans pre-harvest to post-harvest on diverse, fresh, and minimally processed horticultural foods from annual row crops to tree and vine commodities. While at UC Davis, his research combined lab and on-farm packing facility research on E. coli, salmonella, and listeria in conventional and organic production systems for the purpose of identifying opportunities for optimal microbial reductions and delivery of safe food to the consumer. In his role at the Produce Marketing Association, Dr. Suslow engages with members in other industry, coalitions, regulators, and the food safety community to educate and advocate for a risk and science-based approach to produce safety. Dr. Suslow also works with scientists to facilitate produce safety research that can be translated into industry best practices. Finally, we will hear today from Kay Felice and Chris Felice of Felice Farms. Felice Farms has been growing fresh produce for 3 generations in San Benito County, California. Kay represents the 2nd generation and Chris, Kay's son, is the 3rd generation to join this farming company. Felice Farms grows both organic and conventional crops, including peppers, onions, lettuce, spinach, celery, broccoli, tomatoes, cauliflower, cilantro, cherries, and apricots. Now, please note that all attendees are in listen-only mode. We do encourage you to share your questions by typing those in the appropriate box on your screen, and we will have our panelists answer as many of them as possible toward the end of the webinar. Now, without further ado, let's dive in and hear Leanne speak.
Good afternoon. Well, from North Carolina, good afternoon. I just want to make sure that I can advance the slides appropriately before I get started, which does not seem to be happening. So I think I'm gonna need somebody to advance the slides. Well, okay. I think there's a significant delay. Okay, anyway, I'm gonna jump in and hopefully it will advance. So I am a professor at North Carolina State University. I'm actually a food virologist. And COVID really is not a foodborne virus, and we'll talk about that a little bit more over the course of the presentation. But the reality is that there are some similarities, certainly in viruses in general, and so I will jump in and launch into my next slide, which is not advancing. So I think I'm going to need some. There we go. So by way of outline, I'm going to talk first a little bit about the virus, then some information on disease and epidemiology, transmission, a large portion on respiratory spread and control, something on environmental contamination impacts, and then management and conclusions. Next slide, please. So SARS coronavirus 2, we also call it COVID-19, which is actually the disease that's caused by this virus, is a beta coronavirus that belongs to the Coronaviridae family. And it causes largely a respiratory disease, but we know that there are different manifestations as well as respiratory. It is about 50 to 200 nanometers in diameter, which is relatively small when you compare it to the size of bacteria. And it has quite a simple structure. So the structure of the virus is, you can see on the right-hand side of the slide. It contains what's called a lipid envelope, which is the orange area. And out of that lipid envelope are these spike proteins, which are actually what connect to the host cell to initiate infection. And then within that is something called a nucleocapsid, which is a combination of single-stranded RNA plus a few proteins to protect that RNA. So really, it's not really alive because it requires a host cell in order to multiply, but it is relatively stable, and because it has this lipid envelope, it is considered what's called an envelope virus, which historically envelope viruses like, for example, influenza virus are pretty fragile environmentally. They, once they hit the outside environment, they usually inactivate very quickly. But that is not necessarily the case for this virus, and that's one of the reasons we struggle so much with disinfection. The receptor for this virus, the host receptor molecule, is the ACE2 enzyme, and that is very important and has many functions in the body. Probably the most well-known function is in regulating blood pressure. Fortunately, unlike some of the viruses that I work with, this virus can be cultured in a cell culture model, and that means we can study it better than we can study some of the other viruses that are important in environmental transmission. However, it's what's called a BSL-3 organism, which means we need to work with it under high containment circumstances. So I'm sure you've heard a lot about the types and severity of disease that's caused by coronavirus 2. And this is a nice schematic that shows you sort of the transition from mild illness up to very, very severe illness. I'd like to point out significant comorbidities being illnesses, underlying illnesses that either increase your susceptibility or tend to increase the severity of disease. This is recent information from CDC. And basically, if you look at overall the number of cases that have been reported, about 22% of cases have some sort of underlying condition. And the most important underlying conditions, or the most prevalent underlying conditions, are cardiovascular disease, diabetes, and chronic lung disease. Other underlying conditions of less prevalence include neurological, renal, and immunocompromised status. Unfortunately, we don't know yet, a lot about long-term effects. There is some data that suggests there is permanent pulmonary damage in a very small proportion of individuals. We're also hearing about actually some potentially psychological or neurological long-term effects as well. And I'm sure many of you have heard about the Kawasaki-like syndrome in children. Hallmark symptoms for sort of classic presentation are these three off to the left-hand side: fever, cough, and shortness of breath. But there are actually a whole cadre of symptoms that might be experienced at a slightly lower prevalence. This is a slide that also comes from the same paper that looks at sort of the gamut of incidence relative to population numbers. I point you to the right-hand side of this table, which gives the incidence per 100,000 population. This is not perfect data because it's not necessarily adjusted for population size, but you will see that the incidence is pretty low in younger people. It kind of stabilizes out in people in their middle years, and it becomes higher in individuals of advanced age. There's been a lot of discussion about case fatality rate. I'm sure you've heard many different estimates on the news and in your readings. And this is just a snapshot of two pieces of data that talk a little bit about case fatality rates. I think the take-home message here really is case fatality rate does go up pretty significantly with age. That may have something to do with age, but it probably has more to do with the fact that people of advanced age tend to have more of the underlying illnesses or conditions that seem to exacerbate the direction that COVID takes relative to a clinical course. I will also point out that the right-hand graph shows fatality rates for different age groups in different populations in different countries. And keep in mind that case fatality rates also very much depend upon the statistics or the statistical means by which those data are being recorded. There we go. There's been a lot of talk recently about ethnicity differences relative to COVID disease. And I'd spent a little bit of time looking into greater detail on this, particularly with respect to, I think we all know about African American communities tending to have a higher mortality rate and a higher prevalence or incidence, I should say, of disease. But there is a similar phenomenon for Hispanics and Latino populations. They actually do have a disproportionate rate of illness. And you can see this on the right-hand side of the figures relative to on a state-by-state basis. The orange means much higher than what you see kind of as a national average. On the positive end of things, the Hispanic and Latino population tends to have a lower mortality rate than does the general population, and certainly then does the African American population. Why is this? Well, there's several reasons. One is that the Latino population tends to probably has a bit of a higher exposure rate because they are overrepresented in essential jobs that bring people together in close working conditions, which of course increases the chance of infection. And sometimes they also live in very tight communities where there is easy family transmission within that community. Of course, the lower death rate or mortality rate is probably, in fact, invariably a function of the fact that this particular ethnic group tends to be a little bit younger than the average for our country. This is actually a slide of hospitalization rates by racial and ethnic group. And this is a little bit different. We can see if you look at the data for Hispanic and Latino populations, their hospitalization rate is approximately 4 times higher than the non-Hispanic white population. So they are getting disease more often, and they're being hospitalized significantly more often. However, their mortality rates are lower. So I want to talk about diagnosis in a little bit of detail because it's important to kind of understand or know what is diagnostic and what is not diagnostic. So the diagnostic test for SARS-CoV-19 disease is the nucleic acid amplification test called RT-qPCR. And that test in general is now done on nasopharyngeal swabs. It looks for the presence of the viral RNA, so it's basically looking for the presence of active viral replication in the initial site of infection. This is the test that is being used pretty universally. The biggest issue with this test right now, it has pretty high sensitivity and specificity. It's about 90% reliable. The biggest issue is that at least most of the instances that I'm aware of, it's taking as long as 1 week to, or sometimes even longer, to get test results. And keep in mind that that people can pop up test positive very rapidly. So if you're judging a person's infection status based on a test that was taken a week ago, that may not be the most reliable means by which to manage infection overall. Antibody detection is really used for epidemiological surveillance. It tells us of past infection, in other words, who has been infected. And it's invaluable for looking at, for example, the prevalence of the illness, the prevalence of individuals who have been exposed. Unfortunately, antibody detection is not nearly as reliable. And the test itself has pretty low sensitivity and specificity and can be highly variable. Just so that you know, if you look at the nucleic acid-based tests, which we use for diagnosis, there's probably 150 out there now that are being used. The antibody tests, which we use for looking at prevalence of exposure, much less many kits out there, probably about 20. This just shows, this was actually the only paper I could find that showed a comparison of commercial RT-qPCR test kits. And these are the ones that tend to be used the most. So they're the most prevalent in the clinical community. And what I really want to point out here is a couple of things. The left-hand axis, it gives the CT value. CT value is inversely proportional to the load of virus that's present in the sample. So a CT value of 35 means that you don't have a lot of virus present, although it is positive. A CT value of 15 means you have a ton of virus present. If you look collectively at all of these different test kits down here, what you're going to find is that, or what you see on this graph is that these perform more or less equivalently. There's a few differences, but keep in mind that a lot of these tests are falling in this 30 to 35 CT value, which is suggestive of one of two things. Either there's not a lot of viral load, or there's some sort of inhibitory compounds that come along with the clinical samples that reduce the efficacy or reduce the efficiency of the test. So I'd like to jump into transmission venues, and this slide is really not, shouldn't be a surprise to anybody. Of course, we all know where outbreaks were occurring from the get-go, and this hasn't changed in large part. Certainly, anytime you have large numbers of people together, particularly in indoor environments that have close face-to-face contact for extended periods of extended periods of time, where people are talking, singing, yelling, and actually even breathing, and where the ventilation is notably not great. Those are all common themes of transmission of this virus. So how exactly is the virus being transmitted? Well, this is a classic person-to-person transmission type of route, particularly via aerosols and respiratory droplets, but there's also an environmental component to it. Now, I don't want to get into the epidemiology a whole lot, but transmission in the case of COVID-19 is really kind of mediated by two major concepts in epidemiology, one being the reproduction number, which is the average number of secondary cases that arise from a single infectious case or index case. And I take into account the fact that the true R0 or R0 is in a fully susceptible population. So that would be representative of the very beginning of the outbreak. And that the number that's batted around is about 2 to 4. So there's about 2 to 4 new cases that arise from any one index case or one existing case. But this is mediated by something called the dispersion number, which is the individual variation in this R0 or in the number of cases that come out of a single index case. And if you have high variation in that, that's very suggestive of a supershedding type of situation. And supershedding is very highly debated right now. And so I'd like to talk a little bit about supershedding relative to what we're currently, I don't know why this is not advancing. There we go. Probably the best example of a supershedding event, which you probably have all heard about, is a choir practice in Washington, where there was a single index case, and by the end, within about 7 days, massive numbers of people, close to 100 individuals, were infected by that one single person. So that's a classic supershedding event where you have many, many, many people infected by one. There have been a couple of recent articles where they've looked at estimating supershedding versus more community type transmission. And this is just an example of a paper that falls into that realm. And in this case, they saw a pretty high dispersion in that R0 value from 1.5 to a high of 12. And their conclusion in this particular study was probably about 90% of cases that arise within the population actually occur as a function of supershedding events, not as a function of kind of regular community transmission. Now, as I said, that's pretty debatable, and there are others who actually would say, well, that's really not true. There is quite a bit of community transmission as well. So transmission itself is mediated by many factors, including things like which bodily fluids contain virus, how much, how long is it shed, is it infectious or not? And then there's this whole issue of symptomatic people versus asymptomatic people. And I want to bring up a couple concepts here before I launch into this. So symptomatic people are people who clearly have symptoms of the illness. We can identify them, we can quarantine them. Asymptomatic individuals are those who shed virus, so we know that they are infected, but the only way we would know that they're infected is by testing them because they never develop symptoms. Pre-symptomatic are individuals who are infected and they shed, and they'll usually shed at relatively high levels for about 3 days before they develop symptoms. And then, but they eventually do develop symptoms. And post-symptomatic are what happens after an individual has resolved the frank illness and goes into a recovery state, but are they still shedding? Now, this is a great slide of the prevalence of asymptomatic SARS in the population. And I point out into the on the arrowed right-hand side, anywhere you see an L means it's a longitudinal study. Those are really the best studies to look at. This column right here shows us what the positivity rate was. The column next to it on the right-hand side shows what proportion of those individuals were symptomatic, or I should say were asymptomatic. And you can see for most of the longitudinal studies, a very high proportion of individuals are asymptomatic. And that's a very important take-home message, because that goes to the question of, well, are we really seeing more community spread rather than super shedding? And we really don't know the answer to that at this point. So what types of clinical samples do you find the virus in? This study actually looked at a bunch of different clinical samples, some which you would never want to have done, such as lavage fluid out of the lungs. The most common sample type is really nasopharyngeal swabs. And you can see here what the positivity rate for known COVID positive patients are relative to these different types of swabs. I do show here saliva, which may eventually be a very good clinical sample for testing purposes, although to my knowledge, we don't have a salivary test quite yet, at least available commercially. How high are the virus titers in these clinical samples? Well, pretty high in the early days of infection. So we're talking here, this is on the y-axis, these are log RNA copies per swab. You're looking at probably 1 million viruses approximately per swab sample. Irregardless of the type of sample that was used, including instances where stool samples are positive. So people are shedding large amounts of virus in these early days of infection, as well as in that pre-symptomatic 2 to 3 days prior to infection, and then the numbers come down. So let's talk a little bit about mechanism of spread. I love this paper. It talks about what they call the turbulent gas cloud hypothesis. So this virus replicates initially in the probably in the throat area. And the hypothesis is that anytime we do anything that involves the throat, we spew out this cloud of both large and small aerosolized droplets. And that includes things like coughing and sneezing, which of course makes sense, but it even includes things like talking or even breathing in a normal manner. We're always spewing out a small amount of this turbulent cloud. And the droplets in this cloud, well, the contents of this cloud really is two things: droplets and aerosol. So if you have very large droplets, that's particularly prevalent in the case of people who are actively coughing or sneezing. Those won't stay in the air very long, and they end up getting deposited on surfaces pretty easily. Whereas clouds of tiny aerosol droplets will linger in the air for a much longer period of time, and they can travel long distances because they're very small. They're very small droplets. And then, so you can see here that these kind of two types of aerosol droplet situations advise us as to how you can potentially control, right? So masks and social distancing are great at preventing you from getting exposed to these large droplets, as is sanitizing and disinfection, because they get rid of any large droplets and associated virus on surfaces. Whereas the tiny clouds of aerosols are best controlled by being outdoors, for example, and having good ventilation, and to a certain extent by masks and social distancing as well. So it turns out that infection is really, if you look at viral infection, there is an infectious dose, okay, which is the amount of virus it takes to make an individual sick. And that, of course, depends on the person and the virus, et cetera, and so on. But the bottom line is the infection process itself is mediated by making sure that you get that infectious dose. So you can get it in two ways. One way is by being infected to a whole big dose at one time, okay? And the second would be to be exposed to smaller doses, but over a longer period of time. And this is a great back of the envelope risk assessment that was done recently, where the investigator said, okay, let's assume it takes about 1,000 particles of SARS-2 to make you sick. Well, if you're exposed to a person who's talking and who's sneezing or coughing or frankly really sick, you could probably get that in a couple of breaths. Whereas if you're exposed to an individual who's asymptomatic, it's likely that they are shedding at a much lower rate. And so your ability to get infected from them is going to be a function of how long you're around them and how protected you are from their turbulent clouds. And the estimate that they gave was that if you're around somebody who's speaking, who's asymptomatic, it might take about 5 minutes. If you're around somebody who's just breathing and asymptomatic and not keeping social distance, it could be as long as an hour before you would amass enough virus to make you sick.
Leanne, pardon me real quick. We have about 5 to 7 minutes left.
Okay, cool. Environmental contamination, I want to talk a little bit about this. Fomites are inanimate objects that can serve as a vehicle when they become surface contaminated with virus. Of course, fomite transmission is dependent on lots of different things, as in this slide. And let's see. Okay, here we go. So there is proof that fomites do carry virus, and this is an environmental study that was done in China. And you can see here on the left-hand side, there's all kinds of, these are objects in hospitals, from doorknobs to telephones to public facilities, etc. And here's their positivity rates. And you can see that it was very common to be able to find evidence of the virus in those environmental samples. So how stable is the virus on surfaces and in the air? This is a great study specifically with SARS-CoV-2, and the conclusions were that aerosols, about 3 hours, on cardboard, maybe 2 to 3 days, stainless steel, maybe a little bit longer. So the take-home message here is not the specifics as much as the fact that this virus is stable on surfaces and is stable in the air for an extended period of time, which is not the case for most enveloped viruses. They usually inactivate almost immediately. Good news is that UV, ultraviolet light, including ambient air, is very, very effective in inactivating SARS-CoV-2. So not only if you're outside do you benefit from the dispersion of the virus, but you also benefit from exposure to ultraviolet. In terms of disinfection, we know that about 1,000 parts per million chlorine works, about 0.5% hydrogen peroxide, and certainly anything more than about 40% ethanol are very effective against this virus. We have a lot less data on things like benzalkonium chloride and some of the other more novel disinfectants. And so the take-home message there kind of becomes there's a lot of unknowns relative to disinfection of this virus, particularly for some of the, this is not advancing. Thank you. Specifically for some of the EPA Endless products, which in many cases are vastly overrepresented by quaternary ammonia products. So that's not to say they don't work, it's just that we don't know how well they work. Just since this is a group of people who are interested in foods and nutrition, this is a report from a French agency that did a really nice modeling study and concluded that this virus can be inactivated in about 4 minutes at 63 degrees centigrade. Maybe if you're in a food matrix, it might take a little bit longer than that. As a benchmark, keep in mind that standard pasteurization is 62.8 degrees centigrade for 30 minutes. So standard pasteurization should work to inactivate this virus. Okay. So how do we control? Travel restrictions, social distancing, personal protective equipment, hygiene, hand hygiene, and containment. We now, I think, pretty much rely on cloth and surgical masks, and many states actually have mandates for them now. There was big debate when that initially went into effect. Masks work really because of two things, because of filtering and because of the seal between the mask and the face. And they do help prevent transmission, and there's pretty clear evidence to that effect. The benefit for many months was thought to lie almost entirely in preventing escape of infectious material from an infected person, so protecting your neighbor. But there is kind of some emerging evidence that actually you might actually be protecting yourself by using a mask as well. Okay, and I'm going to pass over these next couple of slides so I can, yeah, here's a great slide that kind of shows what the combined impact of physical distancing, face masks, and eye protection might be. And again, this is a kind of a risk modeling study that shows your risk reduction of about 82% with a 3-foot distance. And then that doubles with every additional 3 feet. And community use of masks reduces your risk by about 44%. And that's masks in general. That's not a particular type of mask. The last thing I really want to talk about before I conclude is this whole issue of the potential for food transmission. This was the opinion of the French Agency for Food, Environmental, and Occupational Safety and Health, and this was kind of the first report that came out that showed that there was really no evidence to suggest that consumption of contaminated food leads to infection with coronavirus 2 through the digestive tract. They were careful to caveat that with the fact that it would be remotely possible that respiratory infection could be initiated by by contact, maybe in the throat with contaminated food. There's really not a lot of evidence to support that. And I think kind of the major take-home message here is that while it's not impossible, we don't want to get sidetracked by being wrong or being highly concerned about a rare event when we already know that there are some very distinct things we can do in order to prevent transmission of this virus. And again, it's not okay. And these agencies, there are other agencies that have really come out with the exact same statements using slightly different words. That includes the CDC, the FDA, the USDA, and the World Health Organization. So Trevor is probably going to talk about a lot about food industry actions. I'm going to give you a list here. My expertise and my involvement has largely been with processors, not with farmers. I can say that most processors are definitely doing symptom and temperature checks, using face coverings, putting in physical distancing, minimizing close contact. Hand washing stations are now all over most processing plants. And there are many, many, many other interventions that have been put in place, and they're listed here. And included amongst those is kind of pretty routine contact tracing that's being done by most processors now. So to conclude, I'd like to say it's clearly complicated. I can't stress enough that there isn't compelling evidence that this is a virus that is transmitted by contaminated foods. We know very little about immunity, nor do we know about mutation, and those both have important ramifications relative to vaccine development. We didn't talk about herd immunity, but the current thought is that we would need 70% or more of the population to have infection and circulating antibodies or a robust immune response before we can stop any kind of epidemic proportion types of clusters occurring. That means we're going to continue to see resurgences, and we're going to see pockets of infection and illness. And perhaps those are mediated pretty extensively by SuperShedding.
Thank you so much, Leanne, for the thorough review of COVID. We're going to keep moving and jump into Trevor right now, but you will all receive a copy of the presentation and it will be recorded. So don't worry, you will get Leanne's slides as well. So